Well, thank you, Dr. Newell, for sharing all of the advances in telemedicine with us this afternoon. What a great presentation. And we are on to our final solid presentation. We're going to be talking with Laura Ross, and she has been a cardiology physician assistant since 2004. She graduated from Rosalind Franklin University of Medicine and Science in Chicago, Illinois. She works at the Park Nicollet Heart and Vascular Center near Minneapolis, Minnesota. She is inspired by her relative, whose actual quality of life improved after a heart valve surgery when he was 102 years old. The variety offered by rounding in a suburban hospital and clinic, as well as outreach to a more rural site, has provided opportunities to do a little bit of everything in cardiology for Laura Ross. She's actually done everything from managing CHF, arrhythmias, coronary artery disease, structural heart disease, and prevention as a clinical lipid specialist. It has been an honor to be elected to the ACC Interventional Leadership Council. She's also been an executive board member for the Association of Physician Assistants in Cardiology and the Minnesota ACC Chapter Council. Opportunities to present at conferences regarding the importance of all of these areas have been at the top of her priority list, and she's been very honored to be a part of that. She's joining us today. It's Laura Ross. She's going to be talking about COVID and heart disease and the technology that's going to help us in that space.
It is an honor to be here at the Rock from the Heart event. My name is Laura Ross, and I'm a physician assistant in cardiology at Park Nicollet Heart and Vascular Center, Cardiology, and Methodist Hospital. I'm excited to talk to you about how COVID-19 can affect the heart, how patients with heart conditions can be affected by COVID-19, and how we can stay safe in a pandemic while using technology to monitor heart symptoms. And hopefully I can answer some of your questions about the vaccine, the COVID vaccine, along the way. COVID-19 most often affects the lungs, causing respiratory symptoms, but it can also present with heart symptoms such as chest pain, palpitations, feeling dizzy, or actually passing out. It can start an inflammatory reaction, and sometimes this affects the sac around the heart, called pericarditis. It can actually also affect the heart muscle itself, called myocarditis. This inflammatory reaction can cause lots of problems with other symptoms as well, and also cause thrombotic presentations like pulmonary embolism or blood clots with patients who develop COVID-19. We will also find that some patients develop an elevated troponin. This is a blood test that shows an elevated enzyme that's only released from heart cells when they're under stress. This is a way we can measure heart attacks, but the mechanism in COVID-19 and why the troponin goes up is much different. But we do know that it can affect the heart. In fact, there was a study listed here from the Lancet that did cardiac MRIs on patients who had COVID-19 and heart symptoms. 58% of those patients had evidence on cardiac MRI of swelling of their heart tissue or fibrosis, a hardening of the heart tissue. It also showed changes in the right side of the heart. When our heart gets blood and wants to get it to the lungs to get oxygen, it pumps it from the right side of the heart. And unfortunately, with a big infection like COVID-19 going on, the right side of the heart can start to have changes as well. We know that there are risk factors that can lead to a higher rate of COVID complications, such as age, high blood pressure, carrying extra weight, diabetes, coronary artery disease, and also congestive heart failure. Thank goodness, valve disease in itself isn't a risk factor for developing complications, but certainly if you have any of these other comorbidities, that would be a risk. And with the higher risk of complications, we know there's direct mortality from the COVID-19 infection itself, but also some indirect mortality because people are delaying care. And we're going to talk about that more next. So this slide looks at hospitalizations in Massachusetts for heart problems in the months or the weeks before COVID-19. And you can see all of these hospitalizations are fairly similar week to week. The blue line is admissions for chest pain, the red line is for heart failure, and so on. And each week they're about the same, but come the end of March, there was a significant drop off in hospital admissions. There's another study that looked at the United States, and Minnesota was one of the 9 sites that showed a 38% reduction in heart attack admissions. Now, those of us that round in the hospital were wondering, where did these people go? How can you not have care for a heart attack. And unfortunately, time is muscle. The longer you wait to open up an artery, the more damage that can happen. Things like aneurysms or bigger heart attacks or weakening of the heart or heart failure if people delay care too much. And that's what this next slide shows. Now, each column is different rates of weekly death rates of cardiovascular disease. The first column shows the blue line are death rates related to ischemic heart disease or heart attacks. The red line is 2020, the blue line 2019. And you can see in the spring, the red line significantly jumped up in weekly death rates from heart attacks. Now, thankfully, as we got better at COVID testing and protective equipment, people felt more comfortable coming in, and we see the lines start to merge together there toward the summer. Heart failure admissions were similar between 2019 and 2020, but you can see hypertensive heart disease. There's also a spike in weekly death rates because patients were delaying care. Not only were patients delaying care, but for some people, we were telling them to avoid the ER if they could and also forego testing. In fact, in the pandemic, there was a large study that looked at 909 centers. Procedure volumes, which included anything like an ultrasound, echocardiogram, or coronary angiogram, decreased by 42% from March 2019 to March 2020. The angiogram is important in recognizing if someone is at risk of having a heart attack, looking at the blood flow to the heart. And as you may know, the echocardiogram looks at the ultrasound picture of the heart and the valves as well. Unfortunately, in lower income countries, there is an additional 22% reduction in cardiac procedures. And so people were not just avoiding the ER and hospitalizations, but they were foregoing testing. And as providers, we wanted to keep them safe. We were avoiding it as well. So how can we prioritize care in a pandemic? I think everyone agrees that patients with symptoms take priority. But who else can we prioritize when staff is limited by illness or they themselves are in quarantine? If there's space limitations, we no longer have double occupancy rooms, at my hospital. It also helped to look at what's truly elective so we can really preserve our personnel, our resources. So for instance, if I have a patient who has aortic stenosis and we say every March they get an echocardiogram, but at the same time they tell me they walk 2 miles a day, they don't have any chest pain, any shortness of breath, they're not dizzy, we're starting to learn it's maybe not as important that we get it exactly when we did the year before. Could we wait till that person gets a vaccination? Could we wait to consolidate testing when they come in for something else? It's really symptom driven. And same with lab results. I used to be a stickler at having your monitoring labs for your medications exactly, a year later, but if they're going to get the vaccination in a few months, or they're going to get labs for their blood thinner or with their primary care doctor, it's okay to delay it maybe a little bit just to keep people safe. We've also really investigated virtual visits and telehealth, like Dr. Newell reviewed. It's really been great for our Minnesota winters to be able to offer this to patients to monitor them at home. But if you do need to come in, rest assured, we can take care of you. They've looked a lot at doing surgeries and procedures, pandemic and non-pandemic times. And I found the study that looked at TAVR procedures or surgeries for the aortic valve. Success was high in both groups, whether it was a pandemic or not a pandemic, and there are no differences in vascular complications. So if you need care, definitely come in, be evaluated, and be treated. So what are some other ways we can do remote monitoring if we don't want people to come in? One is the XioPatch monitor. So this is something that your doctor or PA would order to monitor symptoms of palpitations, feeling dizzy or lightheaded, and it's actually mailed to you. It's a little sticker that you wear on your chest. It's a 2-week-long EKG, and it has a little button to push if you happen to have symptoms while you're wearing it, and then you just send it back in the mail. There's no contact. It's a great way to monitor for abnormal heart rhythms or worrisome symptoms without having to have patients come in. There's also smartwatches and phones. These are important because a lot of people have them, and it's a way to also screen for different heart problems. We also are using telephone or online daily monitoring where patients with a condition called congestive heart failure can call in, and we look for subtle changes in their reported weights, their symptoms of swelling or shortness of breath. And if there is a variant experience, it would trigger a nurse to call that patient to check in and try to prevent a hospitalization. We'll also talk a little bit about virtual support groups, including an exciting program for cardiac rehab and doing that keeping safe and remotely. So there is hope. Even when there's times we're limiting testing, there is objective ways to track how your heart is doing in a socially distant, safe way. What I'd like to talk about next are smartwatches. I get a lot of questions about these, and thankfully, they've done some studies on it. So the Apple Heart Study looked at 419,000 participants, and everyone who wore one, they were monitoring for an irregular heart rate. So about 0.5% or 0.52% had an alert for an irregular heart rhythm. Then they slapped a monitor on those people to see what was going on, and 34% of that 0.5% had atrial fibrillation. As you may know, this is an abnormal heart rhythm that's tied to a much higher risk of stroke. And so if we can catch this and initiate treatment if indicated, that can be a game changer. It's not perfect, but I tell people it's better than nothing, especially if they have symptoms that only happen a few times a year, or we can't maybe catch it on the kind of more routine monitor we have. It's a nice tool. If there's a family history of abnormal heart rhythms, it's nice reassurance. Some studies suggest it's not quite as accurate if the heart rate is over 100. So just to keep that in mind. They did another study called the Watch AF trial, which was not quite as many people, 672 patients. And with those people, they had them wear a smartwatch, but also slapped a monitor on at the exact same time. And over 90% of the time, there was atrial fibrillation on the watch as well as the monitor. So it's very accurate. Unfortunately, about 20% of the recordings of the watch were not interpretable. So again, it's better than nothing, and I think this should continue to get better as time goes by. The next thing I wanted to talk about and how to monitor how your heart is doing in a pandemic is to exercise. I think of exercise as a poor man's stress test. Every time you go out for a walk or go up a couple flights of stairs, your heart works harder. It demands more blood flow. It affects your blood pressure, your heart rate, so you can make sure your valves are working okay, the plumbing's working okay, the electricity's working okay, so keep up that daily exercise program. One exciting program that I found out about was at Kaiser Permanente, the health system, where they did a home-based virtual cardiac rehab. Everybody got a smartwatch that collects their daily activity. It sent text to the participants reminding them to exercise and continuously displayed the heart rate during exercise. That data was all uploaded automatically to the patient's chart so that the care team could review that information. And then patients met with their care manager once a week to talk about how it was going and talk about lifestyle changes. Really exciting. So we haven't incorporated that yet at my health system, but I'm really optimistic that it will be easier to do in the future now that there's so many reasons to exercise, but also stay safe while you're doing it. Before that comes to a system near you, though, I think getting a pedometer is a really easy fix to keep honest about how much you're exercising. Our goal is about 10,000 steps a day. And if that's not your style, there's lots of free YouTube videos or streaming online classes, even Netflix. There's all sorts of things to help you make it a little bit easier. Next, I'm going to talk about some mobile devices that have come up in the last few years to help you keep on top of your heart symptoms. So here you'll see the Cardia device. This is about $125, and it connects to your phone and comes with these finger pads that you put your fingers on that act like EKG limb leads. When you have symptoms, you put your fingers on there, and it will give us a tracing like an EKG, and it's FDA approved to do that. When I've had patients bring these recordings in, they're really good, and is great for people who, again, don't have symptoms maybe often enough to catch on a 2-week monitor, but are still having symptoms that are bothersome that we want to get to the bottom of. There's also a few free heart rate apps on your smartphone. So I like the Cardio Heart Rate Monitor. And I found this at the beginning of the pandemic when I had patients I was worried about adjusting their medicine or symptoms they were having, where they could download this, and it uses the flashlight on your phone to check the heart rate. And it's really accurate. Now that part is free. You can pay for additional add-ons to that app, but it even gives you a 10-minute exercise to do that day. It stores what your heart rates have been. I think it's really a great add-on for patients who maybe don't want to get a blood pressure monitor, but really want to know what their heart rate is with exercise or at rest, or when they're at Target. I mean, you bring it with you wherever you are. I get a lot of questions about, what about pulse oximeters? If you can send a light and catch your heart rate, can you check your oxygen levels, especially in a time of a respiratory pandemic? It uses a different light, so there isn't really an app that catches it accurately. Now, the newest Apple Watch will give you a pulse oximeter reading, but on the website, they list it as entertainment. It's not FDA approved, or shouldn't substitute for a medical grade oxygen sensor. But it's interesting. I'm sure they'll develop it at some point down the road. The other interesting technology piece is that I recently got communication from the American College of Cardiology that they would be using these biointelligence buttons to keep track of vital signs for all the participants who came to their cardiology conference in May. It continuously monitors your temperature, your respiratory rate, or how fast you're breathing, as well as your heart rate. And it lasts for about 90 days and continuously communicates to let you know if there's an alert, if you're breathing too fast, or your heart rate's up, or your temperature's up. So I think it's a really fascinating thing to think about as we move into the next phase of a pandemic. When can we all get together again? Will they be utilizing technology like this? So lots of ways to monitor what we're doing in a pandemic. But what about that next step? When can we get vaccinated, and how did this vaccine get developed so quickly? So I hope to answer some of those questions of yours today. So we certainly can get immune responses to fight viruses. Naturally, we get sick, we get an immune response, fights off the virus, but that takes time, and it might not happen before it does damage that could ultimately result in death. Vaccines let us stay one step ahead of the virus. So with traditional vaccines, before this mRNA or messenger RNA vaccine was developed, you needed a big factory to make the protein, to make the virus, and that took time to build and to produce. mRNA is a blueprint. So this messenger RNA is injected in the vaccine, and it's a blueprint to your body how to make the spike protein that's on the outside of the COVID virus. So we no longer need a factory. In fact, our cells become the factory that make all the proteins. So that's one way they were able to develop it quickly. After it's injected and your cells start making the protein, your body will start an immune response to make antibodies or soldiers that recognize that protein and fight it off. You get an immune response. And then those soldiers stay around, ready to fight if COVID comes to your house again, ready to help attack it before it can cause that damage. The nice thing about the mRNA blueprint is that the cells get rid of it when it's finished. It doesn't stay around very long, and it gets rid of those instructions. The mRNA never goes inside the cell's nucleus where our own DNA is stored. So it kind of comes in, tells everybody how to make the protein, and then it's gone. So the vaccine does not use a live virus. It cannot give you COVID-19 because it's just tells your body how to make a protein. And it will not change or alter your own DNA. Now, if you've had COVID-19 before, we still recommend the vaccine because your body may have made an immune response to some other protein. What we know about this vaccine is that it's 95% effective in preventing illness from COVID-19 by going against the spike protein. If you developed immunity to some other protein, it might not be as good. So get the COVID-19 vaccine. And if I haven't talked you into it yet, I do want to tell you a little bit more about it. A little more background about how the vaccines were developed so quickly. Part of it was approved for emergency approval because this is a public health emergency. So for anything to get emergency use approval, it needs 2 months of safety data. And so they started 2 large-scale phase 3 clinical trials when they saw 2 promising vaccines starting July 2020. Each of the trials enrolled more than 30,000 people, and they funded large-scale production while they were collecting safety data. Rest assured, if it was not safe, they would have just shut that right down. But thankfully, we had good data, and they started to give the vaccine out. As of today, when I check the CDC website, more than 32 million people in the United States have received the vaccine. So there have been some side effects when you look at something that large, but thankfully, the risk is very low, even with that many people who have received it. The next question I get are the vaccines safe? My answer is yes. They're being held to the same standards used to assess the safety of every vaccine that we've had available in the United States. I also like to share my vaccine story. So about 20 years ago, I had an adverse reaction to the tetanus shot. I ended up needing surgery because of it, put on steroids, got a rheumatologist, all sorts of things I wasn't planning in my 20s. So I was a little bit nervous to get the COVID-19 vaccine. But when talking to my doctors, we all agreed the potential risks from COVID-19 far outweighed any potential side effects in this new kind of vaccine. And I'm now almost a month since my second shot and feeling great. Just a little arm soreness, but nothing compared to getting COVID-19. The other nice thing I'd like to share is that the CDC is monitoring things so closely. You have the opportunity to sign up for check-ins with the CDC on a regular basis. At first, they send you text messages every day asking how you are. Do you have a fever? Do you have muscle aches? Do you have a headache? And you just quickly answer the questions. After about a week, it goes to weekly questions, but I'm still getting text messages. And my first vaccine was on December 22nd. So I think they're keeping close tabs on us because it is so new to make sure that that safety data still holds. The next question is, will there be side effects? Well, yes, there can be side effects, but they're really more of an immune response. It's not actually COVID symptoms. Most common is fever and muscle aches. And these typically last for a day or two. Within my colleagues, that's exactly what we found in our group in cardiology as well. Another question is, do I still have to wear a mask? The short answer is yes. Not everyone you meet will have gotten a shot. And so while the vaccine is 95% effective, there are 5% of people who it hasn't been effective. In fact, you could still have COVID-19 colonizing your nose when you're talking to someone or your respiratory tract. And although you're not getting sick, you could still pass it to somebody. So we do still recommend wearing a mask, keeping a safe distance from others, and washing your hands. So, should we get the vaccine if you're a heart patient or if you have a heart valve problem? And the answer is yes. That's a short answer. You heard my long answer here. Okay. So, in summary, to stay safe in a pandemic, I hope you understand that it is still important to wash your hands, wear a mask. It is still very important to seek care if you have symptoms. And it's important to really consider getting vaccinated to keep yourself safe from potential side effects of COVID-19 or side effects that could affect your heart if you have a risk factor and risk of serious illness. And also there's lots of tools to use technology to stay safe during a pandemic. So I thank you so much for this opportunity to share information about COVID-19, how it can affect your heart, and how to stay safe. Thank you.